Can you hear me? Can you hear me? We're good to go. It says it's green. Are you picking up on it? But does that move when it's... Okay, we're good to go. All right. What's up, man?
So you're taking your whole family again?
Yeah, man. It's going to be awesome. Okay, so this is Kitana. She's 22 years old. She'll be 23 in just 2 days. And on Wednesday, she turns 23. Grandma and Grandpa are giving her a very big gift today. So we're going to do an all-on-4 surgery on her. A lot of doctors and people out there wonder, is this really the best option for her? And so I think that she's been to a lot of dentists, and she had bad experiences as she went to other offices. She felt like she kind of got the runaround that most people, either one, didn't think that she could afford it and didn't want to give her the time of day, or two, they just didn't treat her very well. And I think a lot of times what happens is patients, they already have preconceived notions of kind of what they expect in an office. I think oftentimes well-intentioned doctors and staff members just aren't as sensitive as they need to be. And so she went to a number of places where she felt that they were judging her, and they felt like she, for one reason or another, she left feeling very uncomfortable to the point where she put this off for quite a while. And but at a certain point, people get to this place where they realize that they can't live anymore in this place, where they're so ashamed to smile. They're so afraid to eat anything that they really like because they're afraid it's going to break their teeth. Get to this point where the pain of not doing anything is worse than the future. And then at that point, it's when people actually start to really get resourceful. And people that have no money, and they've been telling themselves they have no money and have no way of making it happen, all of a sudden they find money, or they get another job, or they start working on their credit. And so in Kit's case, her teeth are all bombed out. She's had a history of neglect, and we'll just leave it at that. I'm the last person that judges her, because I have lots of friends, family that have struggled with some of the same things. And so all we care about is that we're going to change her smile. What's that? That looks really... Yeah, I think it's good.
Closer.
We could probably get tighter. Just go in just a little bit more. Yeah. So if you look here, you know, all these teeth have huge cavities in them. And we'll show you the bottom in a second, but this is, we can see that's just visible. And does my light actually make it worse on the camera?
Yeah, the voice is good.
But is the light better without it?
No. No, what you want?
Okay. So just gross decay in all these teeth. You can see it in the x-rays too. And so there's a couple bad infections in here also. And so what I notice is, yeah, very, very deep bite. Can they see that? Maybe we should come out just a little bit. So super deep bite, which makes her have a very, very square looking profile. And then if you look in the CT, which I'll show you later, she has a very square chin right here. I mean, you can feel it. Feel it right there. So we're going to drop her chin down, open her up. And then the other places where she's deficient is she has a deficiency in both arches, right above and below her teeth. So if you look, very deficient right here. There's a big drop, big gap right there. So that makes so her lower lip falls into there. And then the other place is down here. She falls. So we have some work to do here today. Okay. Alrighty. We're up filming too, so you know. Okay. I'm going to keep that like that. Okay. So we did an interview with Kit on Friday about her surgery, and she was just terrified. And so I found out a little more about her. And this gal's had kind of a rough go. Luckily, she has some grandparents that care deeply for her, and so that's who she lives with. But not all of us are so lucky to be born with parents that are able to take care of us, or either be financially or emotionally, or. But this gal was blessed with some great grandparents. So what we're doing right now is just numbing her up. People always ask, why do you numb her up? We do that because even though she's under general anesthesia, the body still feels pain. And so we still want to control her experience, her body's experience. We don't want her body to become stressed. Stress creates swelling and inflammation, and so that's what we want to control here. Okay. Right here more. All right, that should be good. All right, for scanning purposes, let's choose the teeth that we're gonna. So we have pretty decent pout. Make sure we capture that. We want, and we opened her up somewhere like here, so like this. See if the angulation. See your teeth come out like this. So her teeth have this inclination. This is why her lips are so her teeth have this inclination, but then you'll see that it drops in like this. So this is the inclination of her bone. So teeth here, bone there. So, and if you're to say, how does that look with the profile of her face? Well, her profile of her face is more like this here. But then her teeth are there. So we're going to bring her teeth out like 15 degrees to follow the angulation of her face. And then we're going to beef up a little extra lip support up here too. And on the x-ray, yeah, man, she has just decay everywhere. I wish you can see that there, huh? Let's put this up here so I can, so that we can just show the. And hit the zoom.
So short.
Okay, so has really deep infection in here. She has some infection up in here and here, and all these teeth have gross decay inside of it, you know. And so bombed out teeth. We're going to pick a couple of these teeth just to be able to keep, just for records. So we're going to keep one of these teeth in the front, and we'll keep a tooth in the back, maybe this one, and perhaps this one. 3 teeth on the top, 2 teeth on the bottom, just for us to get our records, so that we can match them up and give her some teeth tomorrow. But just so much. I see how it's just really, really bad decay everywhere. Okay. Okay, let's do the surgery now. And again, I talked to her at great length about her options, that even though her teeth are all bombed out, that she could choose to do single implants and some crown and bridges also on some of those teeth that still have some good structure. And she said no. She said that she's scoured the internet, researched everything. She's a closet dentist and she wants this done. And she said that she trusts me, so that even though she's so young, they'll do everything I can to put down the foundation that will last. And of course, you'll see the live interview. I was really clear about the fact that I could do everything right in this surgery, and if she neglects it, then it's on her. You know, it's like I'm going to give her a Mercedes, but if she doesn't change the oil in it. Christina, give me some water. Water? Yeah. So rather than try to explain what I'm doing in this surgery, I'm going to tell you maybe not so much what I'm doing, is more the things that I'm doing that are going to help long term with her. So one of the things is making sure that she has good bone quality and good soft tissue. So sometimes we're just sometimes really just narrow. We can narrow our focus and think bone, 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 bone. But I actually got into a place where bone is important, and I plan on, it's a key principle. But the part that I worry about long term is if a patient doesn't have good gums, if the gums or the soft tissue isn't healthy, or if it's really thin, that can cause really bad problems. I've been doing this long enough, and I've seen this happen where things look great day after surgery. We place our final device, looks good, and then over time, you have patients come back and their tissue starts to get irritated, and then you start to have that slippery slope where if you don't do something quickly, you're going to start to have bone loss. So, you know, like on her lower, which we'll look at, she has very, very thin soft tissue. So we're going to do some things today to help that. So long term, these implants need to be housed in a place where they have good bone and good soft tissue, because the soft tissue is what keeps the vascularity, helps keep the bone healthy. So if what I'm doing right now, if I was moving too fast and I didn't have sharp instruments, this would cause the patient a lot more swelling too. What I'm doing is I'm just kind of getting underneath this really critical layer called the periosteum. And if a doctor's moving really, really, really quick, and he doesn't have the right instruments, like this one here is a unique instrument that gets in these tiny spots. I'm just kind of just peeling back this layer. And the thing about it is that, again, if you had an instrument that was more blunt like this, see how that can't get to it. So then it scrapes the top portion, but you don't get underneath. And it's when you don't get underneath this layer where you can have a lot more swelling. It's not going to hurt the surgery, but the patient's, and I think that's her biggest fear, was that she's going to be in so much pain. And I am, I am a little concerned that I think, because pain is two pronged, right? You got physical pain, there's emotional, just anxiety, and she definitely has a lot of anxiety. So I wouldn't be surprised tomorrow if she's not one of my patients that tells me she's in no pain, because, but I hope so. These little tiny creases here is where you have to slow down and do it a little bit slower, because it's like microsurgery. Sometimes you can move fast, sometimes you got to move slow, and this is one of those ones where you can see why she's so deficient there, She just has, with the way that's looking at, give me the elevator. We're gonna let the body do some extractions for us here while we're still unraveling everything. Okay, which ones? Let's keep. See here. Pretty square. So maybe we go with an implant on the canines each, and then one in the lateral or the central. So we'll go with. So we'll keep this one. Which one's more stable? Let's keep this one. We'll take that one out. So we're gonna put this back here. Actually, it's okay. I thought maybe it was going to be really, it still could be, but the extractions, take out the buccal plate, start extracting. But I think it'll be okay. So, Mike, I was trying to explain that we numb people up, even though we're under general anesthesia, that because the body still feels the pain and it creates a stress response. So, is that right?
Yep.
Would you explain it any way differently?
No, all anesthesia does is change your body's perception of the pain. So you sleep through it.
Okay.
It doesn't actually change the pain. It changes how you react to it.
And so, if someone asks, like, well, if you're not going to remember, why does it matter? How would you respond to that?
You're going to wake up a lot happier.
Yeah, because your body's hasn't been going through a stressful response, so that, yeah, okay. Just checking my facts.
If you don't go in for heart surgery and because they're under anesthesia, it's not like you don't get any pain medication.
Right.
Your gallbladder or the surgeon still numb up before you make any decisions.
Okay, I'm gonna keep this housed up for this first. Let's do this side. Okay, so let's go ahead and give me 150s. We're gonna keep this one. So that's nice extraction. Didn't take any bone out. Okay. That's good. Let's go ahead and we're gonna put an implant in. So let's keep that one. Let's take this one out here. Very thin bone, but so it's not easy to keep that bone there. Okay, so that's good. Okay, Let's put an implant in here and there. Okay. Let's take under. So we're going to take all this precious bone. Very thin bone anyways. We reflect the back side of that. So in On-4, we do take bone away, healthy bone, but we do it for a couple reasons. One, unlike some other implant surgeries that are out there, the goal is to replace teeth. This is a complete smile replacement. We're not just taking away, we're not just replacing teeth, we're replacing teeth and smile, so the whole thing. So gums, everything. And because we're doing that, we are building the gums in. Why would someone want us to do this? Because long term, if she wants to maintain a really nice smile, if we build the gums into it, then if she goes through a phase in her life where she's not brushing her teeth, or she gets pregnant and she has pregnancy gingivitis, again, the gums always change over the years. Anybody straight? So people sometimes will say that it's really traumatic, it's really aggressive. And I think that my response to that would be, well, if you put teeth in there that last 5-10 years and the gums change, and then you have to redo the whole surgery and extract implants, which is more aggressive. I'd rather do it once the right way and then build the smile in at the same time. And again, this isn't a good treatment for everyone. I'm not saying that, but what I would say is that this is the most predictable way to give someone a smile long-term and short-term. And we're not taking a ton of bone away, but we're taking enough bone away that it provides her with, because we want to replace the gums. And when she was smiling before, she would only smile to there. Like that's what you'd see. That was her high smile. But then this morning I woke up and I said, I know she can smile higher. So when she smiled real high, she went like up here. And so when she does have a really great smile, that's what's going to happen, is that all those muscles that she hasn't used forever, she's going to start to use them again. And if the doctor didn't plan on that, you end up having this really, really awkward conversation with the patient when it's like, yeah, doc, I love my teeth, but when I smile, I'm showing the corners of my teeth and the top of my real gums. That's a bad day. So you got to be careful. When your doctor does this, you have to be very careful to make sure you smile super high so he can see where your smile line is. And it's not what it is now, it's what it could be in the future. It's like I tell people, imagine you just won $1 billion, what would your smile look like, right? Or Christmas morning when you're a kid, you smile super, super high. And you'll see, like we most time when we take bone off, we're we cut it. Like the majority of the bone I took out was cut out, and then I actually replace it. So it's not so much I'm cutting her bone as much as it is I'm redistributing it. I'm taking out the bone and I'm actually going to lay it across up in here and across here. So it's like a restructuring. So now that's about 15, about where we want to be. And this is why I take my phone, because this one is that close. I'm going to pull it up to see where she was smiling right before surgery started. Okay, now relax them again. Side profile here. Okay, smile again. Perfect. Now relax your lips again. Okay, relax them, close them. Yeah. Now go ahead and give me a smile as quickly as you can. Okay, good. Now go high. Perfect. There we go. That's what I'm looking for. That left side has a higher. Okay. Smile again. And when she smiles from the side profile, it gets even worse. Okay. All right. So that's why I always take that video right before, because it's a good, you know what I mean? Because it has to be so accurate. And she's got such a long life. It's like, you don't want to mess a 22-year-old, right? Like a lot of doctors don't want to take cases like this because there's such a high responsibility. On top of it, she's got an anxious personality too. You know, she's a worrier. And so not necessarily makings of the most stress-free long-term relationship, you know, but you can't turn people away that really need your help. Well, you can, and I do actually sometimes, but she didn't give me the indication that I was so worried that we couldn't work through some of the anxiety. But if you look at our interview, I interviewed her last week, and it was really good because I spent time really helping her understand. On video, I caught it too, and I think this is really good because sometimes people forget what you tell them. And so I let her know, it's like, listen, if you don't take care of these teeth, they will fail and it'll be on you, your responsibility, not Dr. Hendricks. And in the healing, if you break your teeth, your temporaries, that's on you because you're supposed to be on a soft diet. And if they have a failed implant, that's on you. And you know, because the last thing I want her to do is to treat this like she may treat other things in her life where, you know, sometimes we kind of push responsibility off. And I'm not saying her, I'm just saying in general, people, we sometimes like to not take full accountability of everything. Okay, so now we're going to go ahead and, so implant placement's huge. It's so huge. And see, like this wants to push me way over here, but if I go here, then I don't have a lot. So I'm going to come in and actually get way over. We're going to change the profile with these implants also, because I don't want my teeth coming, I want them to be flared out more. So we're going to come in like this. There we go. And that's right up against the sinus, or the nose, I should say.
Let them twitch for a while.
I don't know. I need to be able to manipulate it. That one there, or give me a mouse for this one. I don't care, one or the other. Okay, so what I'm doing is I'm just trying to stop, make sure I know exactly where that nose is. The nose It's important to know right where the border of the nose is. The border of the nose right there. That is the beginning of the nose. You can see right there. I don't know if you can see that, but that's the bottom. Okay. According to this CT, that's right. Yeah, she only has a couple, so I'm right where I think I'm at. So people say, I do guided surgery? And I say, yes, I have a CT up. I actually have 2 CTs up right now. So, okay, so that's gonna be one site there. And then put this right here. And you'll notice a lot of doctors, and I used to do this too, I take all the teeth out at once. I don't take them out until, because the teeth act as a way of knowing where my implants are going to go in. Right there. See how it fell in the nose? That's actually what I want. Not a bad thing. It's a good thing because we want to engage in that nose. Okay. Bone's pretty soft. And I kind of thought that from the CT. But I was telling you that we, as doctors, we have options as far as how we want to do surgeries. And people say, do you do guided surgery? And I have everything in my office, all the stuff to do it completely guided. And I choose to do it this way. I feel like this way is meaning that I'm doing guided. I have a CT up, but I'm using the teeth as the guide. Nothing works better than the actual person's teeth. Okay, so this is going to be 11.5 or 13. Let me see what I'm talking about length here. So that one is the 1, 2, 3 third line, which equates to, there's a ruler. There's so many of these I can't keep track of all of them. Yeah, you're right at. If we do 11.5, it'd go to the nose. Let's do a 13. We'll just go just a millimeter or 2 into the floor of the nose. So let's go 13. Morning.
You
got some right here, actually, Mom.
Oh, you got some? Okay.
Yep, thank you. That's my mom. I'm on YouTube. Don't run, Mom. Don't run. She's running from me. My mom works in my office, and she always takes care of me. She always brings me water every 2 hours. She sets an alarm.
2 by 13?
Yeah, 4. Yep. Where? That's it. It's getting worse. And this one needs
It's getting worse.
yeah, every time I open it up it has less.
That's tough.
That's broke off. So here, oh, I got this one here, Felipe. Okay. Okay, so this is a Norris implant. It's nice because it has a really aggressive thread, meaning it's great for loading immediately. Let's see if it can I'm going to have to drill this a little bit. So this is a good example of one where the bone at the very bottom is just a little too dense for this to grab in it. So a doctor that's really, really good at single implants does not mean he's going to be good at all on four, because it's a completely different technique. When you're doing single implants, you're not trying to get, you're not trying to load it with an immediate set of an immediate bridge or teeth, right? You're putting the implant in, letting it heal. So you can have a doctor that's done thousands of implants, but if he only does a couple of all on fours a year, you never get really super good and confident at it, because you're not using the implant company's guide on how to drill. It means you have to drill differently. You have to undersize your holes. And so all I did is open that up a little bit more so that, see if I can get this to engage in that really hard bone and pull this implant in. And there we go. So I'm using both these teeth as guides of exactly where my implant, where I want it to be. Okay. Put ratchet.
Here, but it's the short, the longer one.
So I like this implant because it's a nice aggressive implant. Its connection is an internal hex. It's a very common, popular connection. But what I like most about it is it has every implant size all the way up to the zygoma implants that go up here, which we place. Literally start here and they go all the way up here, so they're that long. And that's why I changed them, not because I necessarily love the implant so much, but it has every size. I mean, I love the implant. It's a good implant. Don't get me wrong, I placed them up. But there's sexier ones out there. They just don't have the breadth of every type of. Then you have to start placing different implants in the same surgery. And that becomes just more complicated for the patient long term when you have to take out certain types of screws. So this means make it as simple as possible to maintain and to on your maintenance visits. Okay, let's do this last one here. So the top always takes longer than the bottom. It should. It's the one that sets everything up, right? Building to a smile. There we go. That's the. Okay. Okay, another 4.2 by 13. See, if I took out these teeth really quickly, then you lose this dimension here of where the lip is. So when you're planning a smile, when you're guiding a smile like this, you're looking at the CT, you're looking at the patient's teeth, you look at all the existing features, and you're placing your implants in relation to them. And then that's how a plan comes together. Another 4.2 by 13. Okay. Okay, good. Awesome. Now let's move back to the mouth here. Give me periosteal. Or Betsy. People laugh at me because I have one implant. You can send that one back. I dropped it. It's the first time I dropped an implant in like 5 years.
Oh,
I wasn't playing. So you missed that off camera, but the implant I was going to put in, I dropped it. I think the manufacturer takes it back as long as it hasn't actually hit the mouth. Okay. Now, so we got those first two. Okay. So let's see this. 1, 2, 3. Let's see the CT. It's okay. You don't need to move it. It's fine. Off camera, I'm just looking at CT right now. There's a pretty big infection under that first molar. These teeth are hammered. I think I can get it to the second. So let's take the first premolar out and the first first molar and first premolar. Okay, let's do it. And so if she was under sedation and I dropped that crown and went back here, that'd be a big problem. That's one of the reasons why doing it under general anesthesia when you're comparing your different options with your doctor. A lot of times, and I used to do this for a long time, was I'd do IV sedation, and I have nothing against it. I'll never say that from a doctor's perspective, I have nothing against it. I think that you can totally do it, but from a patient's perspective, I think that your experience is going to be a lot better if you have complete. Have an anesthesiologist there. Because when you're under sedation, you're breathing through here, and we're trying to control the water going back your throat, and something drops there, and then you cough. Sedation, you're awake. Even though you're kind of out of it, you're kind of, you just have to be really careful because you're a lot more vulnerable to aspirating some type of foreign body. When I was in my residency, I ever tell you this? I had a implant go down back. Yeah, I had to go to the hospital with the patient just to get a chest x-ray. And that's not, it's not the worst thing in the world, but at the time I felt like I'd killed someone, now, if it happened, I wouldn't even bat an eye, but, let's elevate these back teeth. So it's right at the
small one?
Yeah. So these are some of the risks, right? I'm kind of going through this surgery as a patient more than a doctor, but that molar is hard. I want to keep that one in as a guide. Well, we want to come out, doesn't want to come out, but I can be convincing. Overhead. A lot of patients will ask in consultation, how do those extractions? Are they going to be hard? I joke that I'm the tooth whisperer. I just whisper to them, they just come right out. See, this one has. Let's take that. So this right here. That's the infection. That thing that's moving on the top there. That's a cyst. So, and then when the teeth are really, the roots are really close together, that causes the extraction to be harder too because there's bone in between there. Okay, so same thing. Let's cut out the extra unneeded bone. Rogers. Yeah. So when I was talking to her grandma, she said, "How long is it going to be?" And I said, "Well, plan on being here all day. The surgeries usually go 5 or 6 hours because we're doing more in surgery than just taking teeth out and putting implants in. We're actually putting together the surgical plan." And but I said, if I stay in there longer to do extra work on her, would you be offended? Would you be upset with that? And I set my anesthesiologist up too because if he's the one that's collecting a check for the amount of time, and I don't set it up saying, "Listen, if we're in there longer, it's because we're doing it even better," right? Like you don't want to push your surgeon to work faster, or like for me, if I know that I have the time to do it the right way, then I'm going to, like last week I did a nice big tissue graft. And I think I'll probably end up doing that same one here too, looking at it, but you don't want to put your doctor to go faster than, right? So I set him up by saying, if I have to stay in there longer to do extra stuff for you, you're going to be mad at my anesthesiologist for charging you that time. Like, I'm going to give you my stuff for free, so it should offset. Mine actually is more expensive. Do you tell them that, Mike? You give an estimate, but like, do they ever say that? Because like, I try to set you up all the time for that because that's the truth. Like, if I was just throwing 4 implants in, suturing up, right? Literally, I could do this in 3 hours. You've seen me do it like back in the day, but I found that like doing this extra stuff, this is the time, right?
I usually give them an estimate and I say, it doesn't mean it won't be shorter, it doesn't mean it won't be longer. But I say Dr. Hendricks is good about making sure that he takes time to make sure it's right.
And like in this case, she got a little extra discount because it was given with the idea that I was going to be doing video, right? So they knew that that my normal fee would be more, but because I'm sharing this with other people, maybe it takes me an extra half an hour, maybe an extra hour, but that's still a lot better. Okay, all right, let's go back. She's probably 12, but remember I opened her up too, so I don't have to reduce as much because I I electively already put a plan together where it was open more. So that's going to probably be the line, somewhere like that there, which is enough. It really comes down to that smile that she gave us earlier. And if I remember right, it was her left side where she showed a little bit more. And let's see if that's where we're at. This is the gum line here. I think we're probably okay. Okay. That's one of the biggest complications in this surgery. It's not an easy one to solve, and that is if the bridge that we make doesn't cover, we call it the transition line. It's where your teeth transition from fake teeth to real gums. You can see the bridge. That is a really bad thing because the implants are already integrated, and now you have to go back and do a new bridge has to be made, but it has to be made in a way where it can still be hygienic. It's kind of a nightmare. And I take pictures a ton, and so a couple of my cases early on, this happened, but I look back at the pictures and like, no, the patient was smiling. I actually built it to the right one, but then the smile changed. And that's what I always tell people all the time is you're not building to the smile they have now, you're building to the smile that you think they're going to have, like worst case scenario. Or best case scenario, that's how you look at it. Okay, that's the inlet there, so that's that. So we're gonna come from here, start here, and tilt way back. Let's put a thing back there for the water, yeah. Okay, so it's good there. But now I gotta make it a little bit longer. Yeah, it's nice. This is the first time using this handpiece, maiden voyage. It's awesome. Hold the chin down and get to that angle. Okay. Oh, we're off again. I really just need to be out farther. Let's lock this up too. See, if we didn't tilt implant, that'd be as far as we go because that's where the sinus is. So you get like a 6 millimeter implant, or if we tilt away from the implant, we can bring one in and go nice and deep here. Look how different it is. Now look how far I can go. So we got like a long implant angled or a short implant because that literally is where the sinus is right there. Okay. All right, let's do one more and then we should be good. Okay, let's go ahead. You know, I think we can get, actually it's an 18. Let me just check one more time. We got 18 and 16, right? If I put in 18, then yeah, let's go with 18. Where's my driver? Not there. Okay. Flat. Okay, so this is an 18 here. You think it hurt till we hit I'm glad I went with the longer one. If I'd done a 16, it would ding it tight until I got to the 18.
Can you go through, or are you?
No, I got where whether I'm on the cortical plate, I don't know, but I know it got tight at the end. Okay, that's good. Let's put this. Let's try to keep all this in the right place. I spend half my time just looking for drills, so let's keep it right in front. I have a little bit of my bothering me where my dad was HVAC contractor and just puts an instrument or something down and loses it in 20 seconds. Okay. All right. It got stable. This implant's nice and stable, but it only got stability in the last like 2 millimeters. So again, we're gonna go above and beyond here and just place one more implant here. be able to be as long. That's the bottom of that implant there. So just see where am I at there. So let's go with, let's see, I think it's going to be 11.5 or 13. Let's go 11.5.
13?
11.5, 4.2 by 11.5. And again, drilling protocol, this is where a doctor can really mess up because if you're following normal protocols that the implant companies give you, you wouldn't have any implants that stick because she has really soft bone. So I've only drilled like a really small hole and I'm going to push this implant into it because for extra stability. So this implant is nice because again, it has implants that go from like an 8 millimeter really short implant all the way up to I think a 55 millimeter implant, which means that it's one connection with all those screws. Think about it like if you had a car and you had lots of different tires with different nuts and bolts, that can be really hard to maintain. Can you see that? Nice. Okay. That's perfect. We'll take perfect. Okay. All right, so let's put the
So someone asking,
it's already gone live.
what started your interest in dentistry?
So I was pre-med for the longest time. I was pre-med, and then I eventually got some advice from someone to look into dentistry because I come from a contractor family, and so just I like to work, I like to make things, and that's what kind of got me. So the connection between dentistry and wood building or something like that, same thing. I tell people at the core, I'm just a contractor, a small contractor. Yeah.
You build bridges too, huh?
What's that?
You build bridges too.
That's right. I build bridges, just small ones. Okay, so now we're going to start to put together the piece that go here. So that is the bridge, this is the connection that I put the implants on an angle to avoid the sinus, and now I'm looking to correct the angulation with an abutment, but it's an abutment that it goes into the implant at one angle and then it switches directions so that it comes out so that I can connect to it in my bridge that I'm going to build with the teeth. So, hey Christina, will you just be like on YouTube, you answer questions that are relative, like just pull it up on your screen, yeah, so that we don't get too okay. So that's a 45 degree, and again, that's the reason why I like this company. It's like nobody in the world is perfect, right? That's why no implant company is perfect either. You just got to take the ones you think are. So this, one of the reasons I love, again, I talk about how much I love this implant. There's things I don't like about it, but it's like my wife, she may say things that she don't like about me, but overall, I do more good than bad, and then she keeps me around, right? No, I'm really picky for sure on implants because I place so many of them. I really do think that prosthetically, it's hard to compete with this implant. I think it's the best one on the market because in complex surgeries like this, it gives me the most freedom, flexibility to be able to. It's like here, it looks fantastic. If you look from here, I got it look amazing, nice and parallel, but it doesn't go into the bite on the lower. So we need to turn that implant to make it to allow that. So we need to come actually backward a little bit. So turn just a tiny bit, and that should be enough to make it so it's in the right direction. And let's see the back one. Most people make the they put so much weight on the surgery, but after doing this for so long, the reality is that it's the surgery. It's not the surgery; it's the prosthetics. It's the building of the teeth. Straight. I need a straight one. Where's the long straight one? So I want to compare these to this here. We're going to put a 17 on that one also. So, going back to what I was saying before, it's starting with the end in mind. It's like everything in life. The clearer you are about what you want, the easier it is to go out and get it. Well, same thing with surgery. If you walk into surgery, you don't know how you want to end up, you can get yourself off track. So now, those three, 1, 2, 3, they're all within the same plane. They're close to the same plane. So now, those three work really great together. Okay. And on top of that, we look, these could, yeah, they're pretty darn close. Did we get the right one?
Yes.
Put these. Okay, so all right now.
The abutments on this side, which is for 45
Oh,
or 30.
they're both 45s. So maybe I could say a different way. As far as when it comes to implants, like what I care most about is that as a doctor that I have as many options as possible to give the patient the most aesthetic outcome. And this implant company is great because they give me more options than anyone else with all on 4. Okay, so we got that. So for time being too, we might as well leave that one there. Let's go ahead. So we're done on, so this left side's done as far as implants. Now let's go ahead and open up. So I didn't actually reflect all over here because I wasn't ready to do anything there. And so when you look again, trying to control patient pain, inflammation, you don't want them to be opened up any longer than possible. So if they're just sitting there open, when I say open, meaning that we have a wound open, like right now because of the blood and stuff, she's opened up, right? So the longer someone sits open, the more swellings there's gonna be. The more inflammation, the more time the body's trying to respond to it. So that's why I haven't reflected this side now. We're gonna do this side now. So again, look at the deficiency bone. The tooth, this tooth comes out here, but look at that big defect there. And nice tiny instruments get into these little defects. Okay. Last time I had music on, we got censored from YouTube, and they wouldn't let me have my video out there. So if it sounds boring, it's because it is. Mike's back there with his nice big speaker going, man. Okay, so we have an implant there. My plan is put one. This is that. So we're gonna do one.
Canines.
Yeah. Okay. Okay. 150. So extractions are important because if you are too traumatic, it can cause you to break out bone that you don't want to be on, right? And so I'm being very careful, but it doesn't mean you have to take forever either. You want to take a long time. Okay, so let's take this one out too. Betsy. Okay, give me curette. See if we got some. Most of the infection's been coming out with the teeth, but let's make sure. Okay. All right.
All right.
Okay, Rogers. And this is just the bone that's in between teeth. Call it interceptal bone. And rather than leaving it nice and, pokey, we cut it off. And by cutting it off, it allows us to put it in other places that we want it to be. And then it also allows us to make a device where we can not only replace just the teeth, but replace the whole smile. So it's like if an implant heals and it lasts a lifetime, is that success? Some people might say yes, but what if there's a big, huge dark space above the implant so that now when the patient smiles, you see a beautiful tooth, but then a big black defect above it. So that's what the all-in-4 is kind of built for. It's replacing the full smile. We're not relying on the patient to provide the gums. We provide the gums for the patient. And a lot of people say, well, you're just taking away too much bone. I don't know. I mean, you guys can judge if this is too much bone, maybe for some people, but you have to believe in your treatment. I believe that my patients can take care of it. I know they're going to have some neglect. And that's why I like this treatment over others. Okay, so let's go ahead and yeah. So another thing that's really important too is that why you take away those spikes and stuff is because we want a nice flat surface below. So if the surface below is all like a rocky and like with lots of bumps, it's harder for people to keep that clean because food gets caught under there. It's hard to floss it out or water pick it out. So we're flattening it down. We're giving the patient every chance to make sure that they can hygienically take care of this bridge. Okay, let's go ahead now. Let's go ahead and place our implant. Duo. Make sure we get it back in there time. So just don't let me set it down. Just take it before. Can't trust me with it, Felipe.
All right.
Okay, so initially I planned here, but I think I'm actually going to step
Kind of,
with this the way it is here. I think that if we put it here,
it's kind of like canine and second premolar and first molar.
yeah. So I think that it'll help keep the. We're not going to be right up against there. We're gonna, but I need to see the angulation of the other one. Yeah, just this here. If we just put this in here like this, that's for the implant angulation, right? So you can kind of get an idea. Yeah. I think we answered that already.
Oh.
How long ago was that?
I just didn't see it on there. Did you, like, you answered it? Didn't you?
Yeah, what made me choose? Yeah, so I initially wanted to be a doctor, a medical doctor. And then luckily I had a uncle, like a distant cousin, that one was in dental school or going to dental school, the other one that was a dentist. And so they told me I should look into going become a dentist first. And I'd already had taken all the courses to take the MCAT. And I'd already paid to actually take the MCAT, which is to get into medical school. And then so last minute, I said, okay, well, I'll take a week and I'll do some shadowing. And I kind of fell in love with it. And that was history. But this is not, it's hard to call this even dentistry, really. Because if you'll notice, I'm showing those pictures, this also kind of comes into, because we're looking at the face. We're looking, we want to augment a lot of things here, not just put teeth in. Teeth are just part of it. We want to make sure that the smile, the face, the profile. And so maybe it's me trying to play doctor. I don't know. But I always say, if I can do it better, then make it better, then I'm gonna go for it. So, and the more you do this, the more you start to pick up on things, how you can change someone's profile and change the way they look from the side. Our case from last week was a really good example of that. Okay, let's go with another 13. So for the viewers out there too, you can see this is the angle I put this implant in at. Okay, but then I put so the implant's put in at this angle, and then I put an abutment on that is 17 degrees, so it'll correct it to there. But I can choose between here, or I can change the abutment, and I can go from here to like there. I basically go up to 45 degrees here. It'd be crazy, but can you imagine?
Yeah.
I guess it's possible. But
Someone is asking, those teeth appear to strike easily. Is that because they were infected?
teeth up. We have to part. Oh no. What? Good, you got the part? Yeah, get it all ready for me.
Okay, sir.
Thank you. You're good. They, to preface that, so yes, the teeth are not in good shape. That said, even bad teeth sometimes can cause a lot of heartache and pain taking them out. Truthfully, I take out a lot of teeth. I'm very, very proficient at it. I don't mean that in a cocky way, but I mean when you're taking out, thousands of teeth a year, you just get really good at it. And so the more important thing is not just getting a tooth out. The more important thing is that you get a tooth out and you preserve what you want to preserve, which means you take it out atraumatically. Atraumatically meaning that you're taking it out and you're preserving the structure of the bone. You're preserving, even when we cut that bone away, I didn't want any bone below there to be cut, right? And that's even more important than, or just as important when you're talking about doing this with single implants. Oh. But see how I'm using the teeth as a guide. That, and I'm looking at her CT.
One sec. I think the titles will be all in 6, right? Or did I come wrong?
I told you all-on-4 is just a concept. And anybody that believes just an all-on-4 is very naive. I think that you should do what you think is right. You can tell on this gal, she back here I put an extra implant because the bone, I only engaged in really hard bone in the last 2 millimeters. In the front here, this is more about trying to improve her facial aesthetics, her side profile.
So the plan was 4.
Plan was 4,
So
and she paid for 4. And
during the surgery,
there's a couple different ways. Sometimes I'll tell people if I put more implants in, you just pay for the hard costs. With her, I told her, and that's usually like the agreement with most people. But with her, I told her if I put extra ones in, it's on me. I'm just going to do it because I want to, and if I just need her blessing that she won't sue me and say, you said you're going to be 4 and you gave me 7. It's funny, but we work as doctors, we kind of worry about that kind of stuff. Let's try, I don't know, I'm trying to think, as I look here, just how we,
11, 5.
because I think, I think that that's going to be too much, but a 17, because this is angled in, I want to go out, I still think a 17 is going to be right, so sorry for that. So yeah, so all on 4 is just, I think I was trying to explain it to someone. The all on 4 is what are the main concepts of all on 4? It's actually not the number. I mean, maybe it is. I don't know. Maybe sticking out. But all on 4 for me is it's the concept that you're going to put one bridge across 4 or more implants, and that bridge is going to replace not only the teeth but the complete smile with the gums. That's my definition. Can't take it away. I own it. It's my. Okay, let's put a 17 on that one now. When I first started doing this, and I traveled all the way to Europe to be taught how to do this by the original creator of this technique. Give me the other flag. Right about here. And they taught it differently. This has kind of developed over the years why I do what I do. Now, hold on here. This one is Felipe. This 17 is, look how long that is.
Mm-hmm.
We got to make sure we're not buying anything that's got high.
Them 200 livers.
Yeah, I don't want to put anything in this high. Look how it changes the platform. So that's way too long.
Yeah, all these ones are like normal. This one.
Because that one's not there. We're just looking at basically we have an inventory of different abutments here that had different heights, and I wasn't expecting that one. So it was just a misorder. But we have another one here. So going back to why is that important? I want my platforms, meaning all these where the implants are, I want them to be roughly at the same height as each other, because then it creates a better surface to clean under. Okay, I need to reverse it. We ratchet. Getting held up by the bone right next to it. It's going to over there so you can see track of it. So when I'm putting that down there, the bone was just getting in the way. And how that would manifest it when the device goes on, the bone would get in the way of it seating all the way. It needs suction there. It's got some bone inside the implant now. And then the device would get loose in temporaries. Just because it never fully went in. So now that's looking really close to each other now there. But see how they're in line with where we want to be. I can turn it a tiny bit more. There we go. Very parallel there. You can see that the more. Okay. And we have this one here. Now that I have something to compare it to, it looks like this could be just even more parallel too. They don't have to be parallel, but it's my OCD. I like to, the more parallel something is, the less strain will be on the screw. Sometimes you can't get away from it. They're just going to be what they're going to be, but almost. I think this one needs to go down more. The implant itself needs to go in further.
Let's check in a second.
Christina, I need some water.
The hampers? Is it hampers? I think it's full, right?
Thank you. Okay. All right, so now resuction there. Let me explore. I got some bone in there. There we go. Okay, now I think I can live with this one. the platform height is just one of those things. It's tiny details that make a big difference. And if everything's the same height, better hygienic device. Okay. Suctionator. Okay. So the problem is the abutment heights are still high. See, this is where the implant, this is where the interface will be. The interface will be there. I'm worried that that's just too high. You know, I mean, we're going back to, I think the future is that she's gonna have a gummy smile. That means I have to re-put these implants in.
Mm-hmm.
Does that make sense? So I got to put straights in here that don't have such a high profile. Okay, give me the ratchet. Ratchet. Okay, don't worry about that, Felipe. Let's focus here. Okay. So we're gonna re-drill this one here. I'm gonna get a straight implant in like this. What?
Here in the middle too.
What's that?
You want to place one here too?
Yeah. Again, it's all about the future. I don't know what her smile is gonna be like, so I'm gonna make it rule. Okay. Yeah, I think this is gonna work out better. That gives in a better profile, I think, too, because when they tip these out, I think it'll be just right. Yeah, it's got the chills. This one's in the way. Hang on to that one there. Okay, so now I'll put a straight on here. Okay, ratchet. Take a little deeper. always want to make sure we leave it open. Leave the door open to 17 degrees. So where's my 17 again? So make sure we keep it in the right angulation. So if we ever want to go back, let's say after she's healed and say she thinks I may have changed her more than she wants to be changed, we want to leave our options open so the 17 can still work. Got some bone there. $17, $30. Okay. Okay, so 17 is perfect if we ever need it, if we want to change that profile. So I have set that up. That's good. This is the one I think we're going to use though. Okay, gives her the lip support that I want. We'll put that there. Leave that in. Let's go ahead and remove this one now. So the plan changed. So initially I thought I was going to use 17, but going back to that high smile line, this one, these angled abutments, it lifts where the bottom of it's going to be. I don't want to take a chance here. Okay, give me the driver. Got it in my hand. Okay, so take this one out here. Her bone is super soft though. If I aim for that edge, the incisal edge, then when I tilt these teeth out, it should just be about right. Let's put a flag in this one too. It's kind of loose, so I make sure I have the same angle here. Gosh, definitely.
Someone's asking if both arches in
Here.
the same day is something like we normally do.
Yeah,
Choosing
normal.
patients from out of the state or what? That's what they're asking.
No, it's better to do one surgery than two at the same time. Because the plan you're doing both at the same time, like it's better to have it, like you should be thinking about the lower when you're doing the upper. I mean, and I think it's always better to do them together if you're going to do them, unless the patient can't do it medically. You know, sometimes you have to split it up if the patient can only go a couple hours of anesthesia. So again, bone in the way here. Let's take away that bone. Step back. Okay. Now, the other part too, though, is if a doctor hasn't done a lot of these, it's maybe it's best that he plans to do two. That might be the other factor to consider too, because it's kind of it's not it's long surgery for the doctor too, so I can see where that might be appropriate. Okay, that one's a little bit higher, so I got to go just a little bit deeper on that implant. I need the longer one. Rogers. Here, put that on there. So I noticed that this one was just a little bit more shallow, so I'm gonna, and I feel like the angulation kind of turned a little bit too, so I'm gonna go down one more time with this and angle it a little bit harder. Okay, let's see visually. Okay. Let's do a mic. Keep this way. Okay. And now let's check, make sure I leave my doors open for the 17 degree. That's great. Okay, so I'll put this 7 straight in here. Okay. All right. So now let's go ahead and let's go and get these other teeth out.
You leave one in the back here.
Yeah. Well, we actually want one on each side. We don't got anything there, do we? This one here, when I was pushing on it to get my thing, it's I extract that and without even wanting to. That's good. This one here, let's look at the CT. Christina, get the CT up for me, please. Okay, so yeah, I'd like to keep that there, but I could probably deal with just two. But it is kind of mobile though.
That's good. Oh.
The sinus is back further here. That's nice. Give me one of the. We'll have to put one of these teeth back in here in the front. Just identify that because I think this one here is really where I want to put an implant. So we need 3 references. So something. Let's see here. Is that it? Okay, good. Now if I can. Okay, so let's put that right there. What was that? We're gonna take this one out. Okay. Okay, give me Betsy. Okay. Oops. Okay. Again, this is just the contouring of the bone to make sure that we have enough space for the device as well as to give room for the gums. Okay, let's flatten it down. But all the bone that we just removed that was in between the extraction sites, that's going to be ground up and it's going to be put back in. It's just kind of donated to a new site. Okay. Now give me the, let's find out where give me the sticker. Yeah. Let's see where this is now. Okay. All right, let's go ahead and put some implants in here. Okay. Okay, let's go with the 16 on this side. Goes a tiny bit shorter. Fill the sinus to the top of that. So, you know what, Felipe, too. Let's go to, you got a 5. Let's go to a 5, a little thicker. The bone is super soft, so we get,
5/16?
yeah. Okay. So we can get this in here. Yeah, I'm liking that. Okay, let's jump. Ratchet. Here's a short one. Okay, good. All right, let's do 45.
Those are 30s.
No, I don't think so, Felipe. I think. Yeah, remember, I think you have mislabeled.
That's the one you got that was a 30. Those are the 45s.
Up on there. Okay. So this side, because we got such good stability, we don't need an extra implant here. This is good enough there. That's good, good there. Okay. The only other thing I want to do is take the platform down on these over here just a little bit more. Just drive them in a little bit deeper.
On that straight?
Right to that. So this one here we can drive. Everything's at the right platform, and I'd like. That's good there. Okay. Hold that there. Okay, last one.
What you want?
Yeah. Roger. Yeah, it's not on out. So what I'm doing is I'm going to flatten this out a little bit more. I want both sides to be at the same level. There we go. Rangers. Okay, driver. No, implant driver. Can't see. Okay. All right, let's flatten it off here. I actually don't want to. Let's cut it up. I want every piece of bone I can get. There we go. Water. Nice and flat. Okay. I feel like this one will go deeper because it's hitting that implant. So I'm gonna replace that one in a different spot. Just like that. That's okay. So just like that. Okay. All right. Let's put this. I think it's straight. Might be too much. So, okay, 17.
Those ones? Or the one
That's
you were
30.
over here?
I know.
So, these are for government. That's a long, the long part of room.
So we're putting a longer implant here, or sorry, not longer, wider implant, more stability. Going back that smile line, I wanted to get deeper, so as I went, there we go. Good. Now that's more stable. Okay, put this inside the plasma. Where's the plasma at? That inside there. A lot of space here. Let me see if I can get this last one in. Okay, good. Redistributed those implants. One was bottoming out on top of the other one. So, okay, let's get me a 45. It's okay, flip out, let me do it. That's on the small one. Just don't hold off. Only because the one in front is still a little bit. That's when I was able to get in, but it was because the angle is bottoming out on top of the other one. So now we're.
Sorry.
Where's my fan? Not on the list.
Huh?
Fan. 45.
No, that's what I was trying to see, which one it was, 45.
That's on a 45. That looks like a 30. 45 on the table. So that's good. Comes together there. Okay.
145.
I want that. Okay. Give me 17. me a 30.
Do you need bone?
I'll do some here.
Okay.
Yeah.
Do you have an idea of how long the gums will heal?
How long it takes to heal gums? Everybody's different, but usually about a month to 4 or 5 weeks, maybe 6 weeks, if you're a decent healer. Yeah. It depends on how well you clean it. You know, if you're cleaning it well, then let's just do. Can't help it, man. It's my OCD for symmetry. Also, just the extra stability here. Me, 5 by 11.5 or 4.2 by 11.5 is fine. Very, very soft bone, and that's what kind of this is why I have so many different implants in my office. And that's why the line this implant company is pretty good because they have such a huge line of implants. Makes it so I have options when a case like this where there's not really an option to wake her up without having teeth. Meaning she's gonna get the teeth tomorrow, but I mean, giving her dentures is not an option for me. Although it's in my consents, but I wouldn't do that. So a little extra stability here. And if you were married to the idea of all on 4 with emphasis on the 4, then you could get yourself in trouble, And I told her that I wasn't going to treat her like my sister. That's how I see it. Is what would I do? And so that's what we're doing here. The right side does have better bone than the left, that's for sure. But okay, straight. Okay, let's put on this last one here, and then we should be good. Let's see that's probably a 30, maybe a 30. And the thing is that what she's gonna have to realize too is that having extra implants like this, we may not actually use all these implants when we go to the final, because it might be might be really tough to clean with all these implants in there. So we'll see kind of how it goes. But I know she paid for 4, but I put 10 more in here, and we'll have to look at that really closely. So that lines up nice there. Okay, grab her. 4 is ideal because it's like 4 wheels on a car, right? 2 in the back, 2 in the front. And extra implants that add in are more for stability for surgery, and sometimes if a patient has a really irregular jaw, like she has a very irregular jaw because we're trying to change her profile with this up here. So I'm literally changing the way her teeth come out of her whole jaw. Okay, let's go ahead and let's harvest and suture. I want, looking down here, her gums look so So we're gonna do the same things we did last week. We're gonna harvest a piece off of here. So give me a 15. Yes, we're gonna take that tooth out. Not that bad of a doctor. We're just gonna. I need the 15. So these teeth will come out after we get our we need to take a scan after we get done here, and then I'll take these teeth out and that tooth. But they're acting as a way to kind of match everything up in our digital workflow. Okay, so
Okay, thank you.
don't pull it; it'll fall off. Just be careful. So what I'm doing is I'm harvesting a piece of palatal tissue that we're going to graft on the bottom, so that she has thicker tissue on the outside where she's cleaning, and because she's 22 years old, and if and she has very thin tissue on the lower, meaning like I'll show you in a second here, but so I'm taking this nice thick tissue, we're going to harvest it and put down there. Okay, so this is what I harvested. This is the PRF. So we're going to take that, put that on the bottom. And this is from her blood. Okay. All right. Okay. All right, let's go ahead. Give me the Norris cover screws. It has to be Norris though, because that we're gonna use that.
Norris. Christina, do you throw the teeth somewhere?
These aren't needed there, right? This is Norris.
Norris.
Because they actually have this in the ICAM 40 now.
Norris.
This is an option.
Oh, that's cool.
That's great. So those don't become as big of a deal now, right? Does that make sense?
Mm-hmm.
Okay.
What posters?
Here, why don't you? We're gonna put them on for me. I'm gonna go Okay. Took a quick break just to eat a donut my mom bought in for me, so got some calories in me. I think we're good to go. Okay, so those are all those cover screws. Where's my light? Take my light off. So again, super soft bone. I expect it to be a little soft, but it's softer than I even thought. But okay, we took that tissue graft. That's why she's bleeding a lot more. Let's go ahead and swap that out. Bam. Okay, we'll take those two out in a second. All right, let's go ahead. I'm on YouTube still. Oh, next break I can talk to you. Okay, let's grab the Algent. We'll take the impression as is. Algent. Then we can take your teeth out and Felipe. These all have to be the same Norris Medical one.
All of those are Norris Medical.
But this one's too long.
Longer than others.
Yeah, it can't be. What heights they come in? Because then maybe I don't have the right ones. You know what the.
So put two long ones. We can switch those long.
Is it just short and long, or does there multiple different ones?
I think they're like just two.
Yeah, so I think they're all have to be short then. Hey, we need Christina. Okay, so we're just getting ready to take an impression here. We're gonna take an impression with this the way it is. Make sure we get all the right ones. Right. Okay. So we work completely digital with the exception of this one impression we take right now. We take it and then we actually digitize it. And that's just because the blood kind of makes it tough to take an impression. We've done it, we do it sometimes, but it just seems to be less of a pain just to, so let's get ready to go. helps with stopping the bleeding. A little bit of so leaving those teeth in, it becomes the link between what she had and what we're building her. So it's like the transition impression to help me line up the past with the future. I've already got a future smile designed. And okay, ready? Let's do it. Make sure this is, yep, we're good. Just, I think that stuff, last time it seemed like it sat, like it cured faster than, so I want to work fast because last time it was like,
You want more time or less?
no, last time, like, get it in my hands quicker. Seems like it's, but it looks pretty good. 1, 2, 3, 4, 5, 6, 7 implants. Again, on 4 is a concept that has more to do with the way you're thinking. On 4 is replacing all of your teeth with at least 4 implants. It's one bridge, and you're replacing not just the teeth, but you're also replacing the complete smile, which includes the gums. So
someone asking if you need a full mouth restoration, can you have an implant for each individual teeth?
yeah, you can. Yeah, and that's what that's what the people used to do or still do. There's doctors out there that still do that. It just becomes a lot more expensive. When you're placing each tooth for an implant, and then the other issue you have is the same thing as what I was telling you about, is that when you replace each tooth with an implant, usually that's not all done at one time. It's usually like a staged approach where you lose an implant, or you lose a tooth, you put an implant in, and you lose another tooth, you put another implant in, and you do that. What the problem with is that you're continuing to match and camouflage what you're putting in with what's there. So you spend more money over your life, but you still end up with a smile that's the same as when you started, or worse, because every time you put an extra implant in, you can't put a nice white tooth in if you have 2 dark teeth next to it, right? So either you kind of have this option, which is full mouth replacement, 1 bridge, or you can do the same thing, but you do multiple bridges. So, you could put, 6 implants in, and you could have 3 bridges supported there. And there's nothing wrong with that. But again, you're not going to have, it'll be the teeth, not the gums. And so your teeth are beautiful, but if your gums start to change, it won't look as nice. And then the reason why I'm not as big of a fan about that treatment, and not that I still do it, or have done it for a few years, but as far as strength, when you have 3 units and they're not tied together, if you're a grinder, if you're clenching your teeth a lot, going under a lot of stress, if the world changes in like 2020 and everything, then you might be a little more stressed, and then you might have issues with teeth breaking. And okay, so that's the impression there. That looks great. Although the front of that tooth, look, I have a bubble right there. Right on the one I need. Right here, I got this bubble. Let's do one more just to be safe. This is last week when I did this. This is the part that I had no idea. Like last week when I did this, I stayed up till 3 a.m. trying to line stuff up. And then when I went in the mouth, I had to redo the whole thing because of just that one tiny detail. And so I should just send it off to my lab guy and make him deal with it. But that's the problem, is when you make these commitments to these people, I have a tough time relying on other people to do it. And so, and I love what I do. And like with her, like this is such a challenging case that I want this to be perfect. I can't help but kind of get a little more over involved in it. My counselor thinks I should get a life outside of dentistry. Okay, so we're gonna take one more impression, so I have a couple of that. And then we're gonna do our 3D implant impression here in a second. Okay. See, it's set up a lot faster, huh? Like that's what I'm saying. Like it's whatever that new material is, it just moves quicker than what I'm used to. Okay. So the scanner that we've used in the past, it just with all the blood, it causes a shine and it kind of glares back. And so something that like this takes us 2 minutes. If we do the normal like 3D digital scanner, it ends up taking like 25 minutes, and then we're good to go. Okay. Okay. What other questions does anyone have out there? This is a good time to take questions. Throw them out there.
Let's see.
If you have any anesthesia questions, Mike is the greatest anesthesiologist, nurse anesthetist. It's okay if I just always call you anesthesiologist. You're not gonna be offended by that, right? Because I feel like people know that name better, and like I don't know. That's not the right nurse anesthesiologist. Okay. Question.
Someone is say she really appreciate how confident this dentist is to like make this surgery alive.
Oh, cool. Well, you know the thing is that it can be stressful, and I'm not gonna lie. Like when I started dealing with some stability issues, those implants, you know, it's like I can't talk and like deal with like stress at the same time, so I go a little quiet. I turned off the mic a couple times because I needed to say some swear words, but no, I didn't swear. But no, I mean sometimes it's definitely put yourself out there going live like this. But we ended up just with it beautiful now, so I'm really excited. So I would say maybe half of my cases I do all in four, another half I'm putting one implant in more. The one thing that you have to be careful with all in four is that if you only have 4 implants, the bite has to be perfect. And if you're a grinder or clencher, you may need your dentist to put an extra implant in, just because sometimes on 4 implants, the screws have just so much vibration that it can cause issues also with the screw just coming loose. We've had that happen too. So there's a lot of factors, and that's why people are always asking, especially on YouTube, everyone's asking, what's the price? What's the price? And I'm always really hesitant to really kind of give pricing. But I know someone's going to ask that here. So, you know, it's like, if you don't have to do extra procedures and you're not a really complex case, you know, depending where you're at in the country, you're somewhere between 15 and I'd say maybe 35 to 40 per arch. I would say, like in my office, it's pretty standard that the surgery itself is going to be around 15, but then it's the prosthetic that you put on top of it. That's the different levels of teeth you can get. You know, if you go on the cheap end, there's some materials out there that they look gorgeous, but they don't last as long. And it's okay. It's like, you know, you can buy a cheaper car and, you know, it's only going to last a few years, you know, or 10 years, something like that. Or you can buy the really expensive car. But either car you have to do a lot of maintenance on, right? You have to do the proper maintenance to make it last. But it's just that some you know, like zirconia is the one that we do here primarily. And I've really kind of stopped doing the cheaper ones, because it seems like even if I tell people this device is only going to last so long, they forget that conversation and they get upset. And so I kind of just stopped doing those procedures, and now I do more the zirconia. But you know, a lot of people are always asking where you guys at. We're in Salt Lake City, Utah. We're only about 7 minutes from the airport, and yeah, that came off. Which, okay, so Um, okay, all right. Got 2 impressions. Both look great, so we should be good. Let's put this on. Let's suture. Okay, so suturing is really important also. And again, this I know I'm probably gonna get doctors on this one. Let me put this in. Yeah. But I'm trying to speak. This surgery is more about trying to show the patients why I'm doing what I'm doing and how that affects you as a patient, right? So suturing, I could take lots of doctors' questions on that, but I don't want that's different time, different place. To me, it's like, why do I suture? What I do? It's because, again, it goes back to hygiene. It goes back to. But before we suture, my assistant made me realize I still have to do some bone grafting here. So let's graft. So this is bone that we actually took from the patient. Okay. And that's the best bone. That's the bone that the body's going to love the most, right? Okay. So to get this graft to take, we need to give it some places to adhere to. So we're going to graft that buccal. Let's do this first here.
So there are some people in the chat saying it's really active actually. There's a lot of people there. So they're saying like someone else like, oh, how can I get this for free? So another user say like, I don't think anybody can get this for free. So why you don't tell them like you give for free? One of the surgeries like.
Yeah, we've done some giveaways for stuff. Like last year, we did a surgery Mother's Day giveaway. And that's why you should subscribe to my channel, because I actually do a lot more that I don't. I think that I think it's good to do pro bono work. It's good to give back. But if you're always have to get recognized for it, but so I try to do stuff, but people don't always know about it. We work with with an organization that we're actually doing a brand new smile for, a organization called Operation Underground Railroad. That's a case that we're doing here in the next month or two. So completely free, that we're just changing someone's life. I'm so excited about that. But getting it for free, that's hard, because this is a surgery. It takes a lot of time, a lot of money. It's really risky surgery. And so it's hard pressed trying to find a surgeon that's, it's kind of sad, but like, unfortunately, we live in a world where we get sued so easily for sometimes doing good things, and but so what I like to do is, like, when I do give people a discount or something like that, I always make sure that they have to be invested. And so I don't ever do 100% free, unless like Operation Underground Railroad. That's different. I'm actually doing that 100% free, but I like people to be invested. Okay, so now you see all those little dots. Notice what's happening in those dots. This gives me the chills too. I love it. So all those little dots right here, they're little channels that are blood. And now I can put a nice graft here. This is what's going to change her facial profile that I didn't even talk to her about, really. I mean, a little bit, but this is the part that I have to be careful to overpromise. She wants teeth and she wants a nice smile. But if I can improve her side profile at all, I think that would really just be something awesome. So we're going to do a graft in here. Let's go ahead and grab me the material again. But that thing is, if you subscribe to our channel, you'll hear about things that we do, we put out there as far as opportunities. A lot of times when I've done pro bono work, it's been on patients that come in and they weren't asking for anything free. They were just finding out. And then I was kind of moved to here, let me do it. This is very, sorry, Felipe, this is so important to get right in the right places. Meaning that, like, I like to give to people that aren't expecting it, that where they're just blown away. And so I know some people probably will take offense to that in some way. Seems like these days everybody gets mad at no matter what you say. But I think where you're going for, Felipe, is that we do a lot more than people might know. That you're saying? Yeah. And especially for existing patients too, that where they say they started with me like 4 or 5 years ago, and I was doing a lot of, at the time, a lot more overdentures and patients, helping them get upgraded to something like this. Because if you've had a snap indenture, which can be very beautiful, but man, they can really just cost a lot of money long term because of all the costs associated with the relines, with the changing inserts out, with them breaking because they're not as strong. So, okay. Are we good? We can take these teeth out now, right? So we have it grafted here. So I grafted all along the buckle right there, okay? All along the outside. Let's take this tooth out now. If she wakes up with one tooth, she may not like me. Thanks for telling everyone that. Everyone, Christine is going potty. Okay, that's good there. So it gives you a good relative to see kind of how.
You still have one.
Yep, and then we'll take this one out too. This one's going to come out nice and easy. Okay. All right. Now, take down this last portion of bone. Just be careful not to suction in my bone I just put in there. So grafting is not indicated. I mean, it's not something that you have to do here. Most doctors that do all on four don't, that I know of, because that's what I know it's taught. They don't graft. I'm doing that. Can you just grab something to push it off? I'm always trying to get rid of it. Just, I'm afraid you're going to suction. Oh, you tear it off? Mm-hmm. Okay. But I like to graft because we have to take the bone away either way. So if we're going to take the bone away to give us a hygienic device, we might as well put more in there. And okay, that's good there. It's the steps that I used to go so fast at that I don't go fast at now. Funny how that works out. The implants, putting them in is really the easiest part we do. It's the details that we pay attention to that make the biggest difference. Like the soft tissue and the grafting there. So look there, I think that should be fine back there. That's good there. That's good there. One little piece. This little piece back here just would cause it'd be, okay, you're moving around. Messing with my head there, man. Okay, all right, let's go ahead and let's suture down. Okay, I'll put some, here's those PRF. Okay, that's from her blood that we took right at the beginning of the surgery. That helps with swelling and inflammation. So PRF is, like I said, it's from the blood. Blood, when you spin it at a certain RPM, fractions out to different layers. There's the top layer, which is more liquid, and it's where your platelets are. Or your, Mike, what's the top layer?
Blood?
Yeah, the blood. You know, there's layers. There's red blood cells, white blood cells, and the top is plasma. Yes, I could. Right. Okay. And then I'm putting it in places where the patients usually report a little more sensitivity. You know, like right here, it's an area that's, I'm gonna stick it right there. Come on. Okay. All right, suture.
Dr. H, how long do you have to study to be a dentist? Christina, we can hear you.
Sorry.
No, Christina's like, huh, because it's funny. I would say I've never stopped studying. I still go to lots of courses, as well as teach courses, but the short answer is dentistry in the United States, we have to go. I think all but one or two schools requires you to have a bachelor's. You just be careful not to go buckle. Okay, go ahead and cut that. And then dental school itself is 4 years. Okay, and that's basically where you have a license to practice. You have a doctorate of dental surgery, or DMD. I think it's doctor of medical doctor. I don't know, but that's 4 years, and so a lot of dentists will just do that. But then I did a residency outside of that that was just in implants, and that was for right around 18 months. And so, but there's other, so maybe a question might be good is, what doctors do this? So you have a general dentist that does this, like me, but so I don't do any general dentistry though. So I'm a strictly implant practice, and most of what we do, I'd say 95 to 98% of what we do is all on 4, or the equivalent, all on 5, 6, 7. This is an all on 7 on the top, I guess. But other doctors, for example, a periodontist is a doctor of the gums, but they also do this too, or most of them do. And so, but the thing about periodontists is most periodontists aren't going to do the bridges. And they'll do the implants, but they're not going to do actually make the teeth and put the teeth in. Still have to go to a general dentist. Then the other doctor within dentistry that would be doing a lot of surgery would be an oral surgeon. But same thing, oral surgeon is going to do the implant surgery, but then you'd have to go to a general dentist or a prosthodontist to have the device made. And so that's kind of why I'm kind of unique, because I am a general dentist by definition, But really, I'm an implantologist, but implantology is not, it's not like a recognized specialty within, like, for example, recognized specialties such as like orthodontics, periodontist, oral surgeon. Those are recognized specialties where, so implants, we kind of like, we share the, we have lots of people who place them, but there's not a one type of dentist that does it. So there's some turf battles that happen because of that. Sometimes oral surgeons think that they should be doing them exclusively. Of course, us general dentists kind of feel differently about it. My opinion is that it doesn't really matter who does the surgery as long as he sees the plans. It's like someone laying the foundation down, but he's never seen the plans for the house, the property. And so the problem you have with one doctor doing one thing and the other doctor doing other things, well, as doctors, we're so busy. Oftentimes, it's so hard to communicate and get everything right. And it's easy to start to have issues with communication. So the advantage of having one doctor that deals with all is one office to go to that can manage the case from start to finish. Go ahead and take that. So, and again, there are some really great oral surgeons and periodontists that do incredible work, and they work really well with another doctor. Sometimes they work like right across the street from each other in the same building. That's actually pretty nice. But again, it comes back to, if you run into problems, who's going to be responsible for them? You know, I get calls at least a couple times a year being involved in some type of lawsuit where, you know, doctor saying it wasn't my fault, and the other doctor saying, well, it wasn't my fault. And it's just like, well, okay, who, you know? So I like it because in my office, there's just me. If there's a problem, I have to own it. And I think that makes you really good at what you do too, when you realize that you're the one that has to solve the problems, you know. Can't blame anyone else besides the patient. You know, patient's the other part of the equation. That's why if you go back to the live video that I did the other day interviewing her, it was on Friday. We did a live video interview, and I really talked at great length about the fact that I could do everything right here, and she could completely go out and ruin everything. And can't see. And so, and it's the truth, you know. And so we put ourselves out there quite a bit. And so patients are like, "What's the warranty? What's the guarantee?" And I tell them, who would put a warranty on something that they can't control at all? You know, I hear these doctors out there like, you know, I believe that there has to be a marriage and a responsibility between both parties. So you want to make sure you're jumping into a relationship with someone you like. So that's why I interview my patients and they interview me, make sure we like each other, right? But and there is patients that you just don't jive well with, and that happens. And so, but once you go to the altar and get married, now you have to live with each other. And so definitely don't want to just be looking at price as the only factor, because if you don't like the doctor and you don't think that he's the type of person that you're going to want a long-term have to work out all the problems with, then you know you probably ought to keep looking. I know that price is a big deal for everyone. I know that that's a big deal, but just don't make it be the only thing. You know, keep looking. Sometimes you can find a doctor that's has the same experience, but just has different personality and just seems to, you know, and the staff just respond. Because we do this all the time, we're very confident what we do. My staff, they don't even know how to do dentistry. Like, we have a patient that we're finishing up on. We did a snap indenture. It was like treatment planned years and years ago, but then she never came back. And now I don't do it removable. None of my team even knows how to do dentures and snap indentures, with the exception to Felipe. And makes it difficult to do that kind of treatment. So we kind of stay in our lane. You know, we did a live surgery back a little while ago too. And I was actually really surprised at how many people got on and really seemed to like the experience. We realized that there's a lot of sick people out there that want to see surgery. But I think it's great. If I was in your boat and looking and thinking about doing this, I would definitely want to see, you know. But some people can't handle all the goriness, the blood. So again, suturing, how does that affect the patient? If the sutures go in too tight, what happens is the wound itself is compromised. It's kind of think about like putting a tourniquet on your hand and forgetting to take it off. So if you pull so tight, it causes the blood supply not to get there. If the blood doesn't get there, then what happens is you end up having a site that doesn't heal as well. And it's kind of unfortunate. So again, sutures one of those things where I used to be fast and I used to be very, 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 very quick. And then as you do this over and over again, you see patterns that, you know, and so you start to adapt and you start to change to make it so you're always improving. And I teach doctors this, you know, they kind of appreciate, I think the suturing is important. It's not about looks. I mean, I think it looks nice, but it's about, so the first thing is how is this going to affect the patient healing wise? If you suture right, you're going to have better healing. Secondly, if you suture right, you'll have better, a better surface when it comes to cleaning. We want surfaces that we can clean well. The number one complication in this surgery, this type of surgery, are patients not having devices that are clean, they can clean, you know. I think as dentists, we're quick to blame problems on the patients, but if we don't provide a device that it is cleansable, then it's really on us. And so part of that is the suturing, meaning that you could pull tissue really tight up against each other and have a lot of bulk. And that would make it so underneath the device, you have this like really weird topography, which is like kind of wrinkled. Instead of what you'll see if my patients is a nice flat surface that, and also it helps me when patients come back for their final testing to make sure everything looks good. You know, implants, gums. If I always suture the same and I take a lot of attention to detail, then I have a patient that has really rough surface, then I know that, you know what, they're not great healers. And that's important to note too. And I'm starting to look and worry, okay, if the tissue didn't heal great, what's the chances the bone healed great? So, okay. All right. Where's that coming out? Hold on here.
That was the first one you
Okay. So all this is extra bone here. So I'm pushing, but not there. Okay, we're good here. Okay, let's go at the bottom. So I'm gonna just show, I'm not gonna show the surgery on the bottom, but I do wanna show the gums because it's really tough to see it. You know, the angle of the camera is just really hard. I'm trying to get some camera equipment so it hangs overhead, but let me just try to show the patients here, or the So the reason why we took that big palatal tissue graft, where's it at? Right there. So hold on one second. So this is keratinized tissue. So there's parts here where you can see so this is nice thick keratinized tissue. Then she has removable tissue that comes up here, like cheek tissue. So I can pull it. So it's really, really thin here. It's super thin right here. You can see there's an infection there also. But there's places that it's really, really thin. And so what we're gonna do is that graft that we took from the top, we're basically gonna lay it in and thicken up all that tissue across there like that. And so that's what we're gonna do. And it will give a much better long-term health for the overall implants and everything. So, okay, so we'll keep looking at the thread and answer questions, but hope that was helpful.